speakers. We have a panel which is not only expert speakers, at the same time, the topics are very, very important and widespread need, and that's pulmonary eosinophilia. Now, to start off, we have Dr. V. Rajesh, who's a consultant pulmonologist in Rajagiri Hospital, Kerala. His MBBS, MD in respiratory medicine and tuberculosis, DNB and diploma in critical care medicine. His area of expertise is antimicrobial use in critical care setup, dual pathology, pathway of inflammation in asthma, and prevention of pneumococcal disease in adults. He has several publications to his credit, and he's going to talk on the overview of pulmonary eosinophilia. Then we have Dr. Ajmal Khan, MBBS DM, MD, DM, presently working as a consultant in Sanjay Gandhi Postgraduate Institute of Medical Sciences. His prominent areas of interest are lung disease and interventional pulmonology, parasitic lung disease, and airway disease. And he's going to give us an overview on tropical pulmonary eosinophilia. And lastly, we have Dr. Angira Dasgupta, MBBS, MD, DNB in pulmonary medicine. And she's an eminent speaker, and she has several publications and is currently associated as pulmonary medicine specialist in B.R. Singh Hospital, Center for Medical Education and Research, Eastern Railways, Kolkata. So we start off with Dr. V. Rajesh, who's going to give us an overview of pulmonary eosinophilia. Dr. Rajesh, please.
Thank you, sir. Thank you for your kind words, and congratulations to Dr. Parthasarathi for once again coming up with these Pulmocon modules. Unfortunately, because of COVID crisis, we are not able to physically meet now, and we are in the form of webinar we are meeting. And again, thanks for allowing me to be a part of it. So sharing my slides. I hope my slides are visible.
Yeah, they are visible. Yes, Dr. Rajesh.
So the next 20 minutes or so, what I'm trying to do is I'll spend a couple of minutes on sharing with you the eosinophil biology and familiarization of the term pulmonary infiltrates with eosinophilia. A couple of minutes on enumerating the causes of pulmonary infiltrates with eosinophilia. A few minutes on the clinical presentation of PI, and maybe 10 minutes on how, as a practicing pulmonologist, we should go about evaluation of a PI and discussion on selected causes of pulmonary infiltrates with eosinophilia. We'll start off with a couple of disclaimers that it's not a comprehensive review of all causes of pulmonary infiltrates with eosinophilia, and specific causes have been more common causes are going to be dealt with by subsequent speakers. And again, because it's a comprehensive review, it will be a superficial discussion, not deep into each cause. So if I can share the eosinophil biology and causes of peripheral blood eosinophilia, the exact function of eosinophil is less clearly defined in the medical field, but it is supposedly involved in host immune response to infection, tissue remodeling, tumor surveillance, etc. What is very clear is that the eosinophils develop and differentiate in the bone marrow, and this differentiation is actually regulated by certain interleukins, specifically the interleukin 5 and interleukin 3, and to some extent by the GM-CSF. The normal peripheral blood eosinophil levels is less than 500 per cubic millimeter or less than 0.5 into 10 raised to 9 per liter. An increase in eosinophils in the peripheral blood or tissues can result from two broadly different pathogenetic mechanisms. One can be a polyclonal expansion due to overproduction of interleukin 5, or a monoclonal expansion as is seen in myeloid and lymphoid neoplasms. Eosinophils are predominantly tissue-dwelling cells. Again, as I said, their functions in health are not very well elucidated till now. Eosinophils in the peripheral blood or tissues can increase in a wide variety of causes. Varying mechanisms and varying disease severity can result. And these activated eosinophils can result in tissue damage by release of various mediators. That's the topic of our discussion today. This is a very broad classification of peripheral blood eosinophilia. It can be due to allergic disorders like asthma, allergic rhinitis, atopic dermatitis, etc. Infectious diseases like helminths and parasitic infections, some fungi, viral infections like HIV, immunological disorders like sarcoid, IBD, IgG4 disease, etc. Specific eosinophilic disorders like idiopathic hypereosinophilic syndrome, CHURG syndrome, etc. Neoplastic conditions, acute or chronic eosinophilic leukemia, other myeloid neoplasms, etc., etc. So these are, in a nutshell, the causes of peripheral blood eosinophilia. All of them need not have pulmonary manifestations, but broadly speaking, allergic, infectious, immunologic, neoplastic, and specific causes. And one specific aspect is drug-induced peripheral blood eosinophilia. Many of the drugs can actually result in allergic manifestations and peripheral blood as well as tissue eosinophilia. It can take the form of asymptomatic eosinophilias, as in the case of beta-lactam antibiotics. It can have interstitial nephritis-like manifestations, like in the case of cephalosporins and penicillins. Pulmonary infiltrates, as we are going to talk now. Hypersensitivity vasculitis that can occur with phenytoin, allopurinol, etc. Eosinophilic myocarditis can occur with ranitidine. Eosinophilic enterocolitis and gastroenteritis can occur with NSAIDs, etc., etc. And the second thing that is of importance to us is aspirin-induced asthma and nasal polyposis. So coming to the chunk of discussion today, that is pulmonary infiltrates with eosinophilia. I am using this term because in most cases, our evaluation will be limited initially to a chest radiograph and a complete blood count. So you see eosinophilia in the peripheral blood count and infiltrates in the chest X-ray. So both of this may be related, unrelated, but comes under the broad term pulmonary infiltrates with eosinophilia. So a peripheral blood eosinophilia of greater than 500 per cubic millimeter with pulmonary imaging abnormalities on imaging studies will qualify for the term pulmonary infiltrates with eosinophilia. Whereas if we really want to make it as pulmonary eosinophilia, then there should be some demonstration of pulmonary tissue infiltration by eosinophils as the cause of pulmonary infiltrates. More often than not, when we see peripheral blood eosinophilia, we take it for granted that the pulmonary infiltrates are due to eosinophilic infiltration of pulmonary parenchyma. Need not be, but most often yes. So if we really want to demonstrate that, we probably need a lung tissue biopsy, but that is challenging. Or a less challenging and more conclusive way would be to do a BAL and do a cytology or differential count of BAL and demonstrate that there is significant BAL eosinophilia. That serves as the indirect evidence. Coming to the pathogenesis of and pathology, the first step is that we diagnose pulmonary infiltrates in imaging of the chest. That can be a chest X-ray or a CT scan of the chest. Secondly, we demonstrate peripheral blood eosinophilia by a simple HPT-CTC or a complete blood count. If that is not conclusive, then we go for BAL examination and differential count to demonstrate eosinophilia. Still not conclusive, go for a lung parenchymal biopsy and demonstrate infiltration by eosinophils. As I said previously, the clarity of diagnosis will increase as we move from step 1 to step 4, but the challenges in diagnosis or challenges in performing the tests also increase as we move from step 1 to step 4. So coming to the differential diagnosis of pulmonary infiltrates with eosinophilia. Previously, I mentioned the differential diagnosis of peripheral blood eosinophilia. If you see the pulmonary infiltrates with eosinophilia, then it can be due to a pulmonary infiltrate due to one reason and eosinophilia due to another cause. Or it more commonly, it can be the same disease causing pulmonary infiltrate as well as eosinophilia. And again, there can be a situation where there is peripheral blood eosinophilia, but we are not able to demonstrate pulmonary infiltrates in a chest radiograph, but which actually may be present in a CT scan if we manage to do it. So there is some degree of confusion as to how we should evaluate. But then, if I enumerate the cause, the commonest causes would be helminthic infection-related pulmonary eosinophilia syndromes. That can be due to transpulmonary passage of ascaris, ancylostoma, nectator, etc., the so-called Loeffler syndrome. Or it can be specific entities, the tropical pulmonary eosinophilia due to Ushereria and Brugia, which is actually coming as the next talk by Dr. Ajmal. It can be due to hematogenous seeding, as occurs in the case of strongyloids, trichinella, schistosoma, etc. Or it can be direct parenchymal invasion by the helminths, as in the case of paragonimiasis. So helminthic infection-related pulmonary infiltrates with eosinophilia forms a huge chunk. Again, drugs and toxins are very important causes. NSAIDs are notorious to cause. Some specific antimicrobials, especially sulfas, nitrofurantoin, daptomycin, etc., can cause PIE. Phenytoin is very well known to cause. Again, toxins like L-tryptophan, rapeseed oil, etc. can cause specific entities like the eosinophilia, myalgia syndrome, etc. Allergic fungal infections are a cause of pulmonary infiltrates with eosinophilia. The classical example is allergic bronchopulmonary aspergillosis, which again is coming as a subsequent talk today. Idiopathic inflammatory and neoplastic conditions like the chronic eosinophilic pneumonia, acute eosinophilic pneumonia, CHURG-STRAUSS syndrome, idiopathic hypereosinophilic syndrome, etc. are important causes of pulmonary infiltrates with eosinophilia. And some miscellaneous diseases including tuberculosis, coccidioids, lung or hematological malignancies, etc. can also cause eosinophilic infiltration. Although diseases like TB and coccidioids, even if they cause, the magnitude of pulmonary infiltration with eosinophils is to a much lesser degree. So important causes: drug-induced, parasitic, allergic bronchopulmonary aspergillosis, the acute eosinophilic pneumonia, chronic eosinophilic, CHURG-STRAUSS, and the hypereosinophilic syndrome. This will be the common causes encountered in day-to-day practice. So how do they present to a clinician, or how do they grab the clinical attention? The clinical symptoms may actually be lacking. It can be an asymptomatic presentation or an incidental detection, or they can classically present with common respiratory symptoms like cough, wheeze, shortness of breath, chest tightness, fever, etc. Or sometimes the extrapulmonary manifestations predominate, as in the case of skin rash or nasal symptoms, GI symptoms, etc. These are classically seen in conditions that are multi-system involvement, like the hypereosinophilic syndrome or the CHURG-STRAUSS syndrome. GI symptoms and multi-system symptoms like mononeuritis multiplex can occur. So how is it picked up? In an asymptomatic patient, it may go unnoticed, but sometimes many of these patients actually seek a chest X-ray for alternate reason, like a pre-op evaluation or pre-migration evaluation, health check, etc., which shows some infiltrates. And obviously, we ask for a CBC along with that. If we see chest X-ray infiltrates, that shows eosinophilia, and thus we make a diagnosis. Again, an asymptomatic person can have a CBC check for an alternate reason, which shows eosinophilia. Then, as part of the evaluation, a chest X-ray is asked for, which shows infiltrates. That way, we make a diagnosis of pulmonary infiltrates with eosinophilia. Sometimes a patient may be symptomatic or may be on a drug therapy. He can have pulmonary symptoms like cough, wheeze, or shortness of breath, or can have allergic symptoms like rash or upper respiratory allergy, constitutional symptoms, etc. Then we ask for CBC and chest X-ray. That way we pick up. Some of the specific aspects or specific challenges in picking up is that although most of these conditions have a subacute course spanning over weeks to sometimes a few months, acute presentations can occur, classically seen in acute eosinophilic pneumonia, acute drug toxicity, and acute exacerbation of allergic bronchopulmonary aspergillosis, etc. Now, although the definition encompasses peripheral eosinophilia, some of the pulmonary eosinophilic syndromes can have absent peripheral blood eosinophilia, at least in the initial presentation. Classically seen in acute eosinophilic pneumonia, around 20 to 33% of cases of chronic eosinophilic pneumonia, and any patient who has been on recent steroids. So that will suppress the peripheral blood eosinophilic response. Extrapulmonary involvement will be very common in CHURG-STRAUSS syndrome, hypereosinophilic syndrome, some of the drug manifestations or drug-induced eosinophilic syndromes, and hematological malignancies. And again, as I said, sometimes the chest X-ray may not be sensitive enough to pick up subtle shadows, as I will demonstrate in one of my subsequent cases. This is a 56-year-old lady with asthma and systemic hypertension. She had a poorly controlled asthma with frequent exacerbations. Admitted with an acute exacerbation of asthma, CBC showed 23% eosinophils. The chest X-ray seemed more or less normal, but the CT chest actually showed retrocardiac infiltrates, and the previous X-ray actually showed infiltrates at some other sites. So these were fleeting infiltrates, and a diagnosis of ABPA was subsequently made with all investigations. So what I meant to say was the peripheral blood eosinophilia may be lacking in a small subset. The chest X-ray infiltrates may not be prominent enough in a few subsets. So probably if you have a high index of suspicion, go ahead with the CT chest and even a BAL examination for differential count. Now, how to evaluate? A very focused history, a very detailed drug intake, travel and food history to endemic areas which have this parasitic endemicity. Go for a history of asthma and poorly controlled asthma, brown flecks in the phlegm can actually point to a diagnosis of allergic bronchopulmonary aspergillosis. Any bowel, hepatic, or cutaneous disease in case of multisystem pulmonary eosinophilias. Systemic features like mononeuritis multiplex or other organ involvement as occurs in the case of hypereosinophilic syndrome or CHURG syndrome. The test that we need to be performed, already the chest X-ray plus or minus CT chest, and we have the peripheral blood examination. CT chest may be worthwhile in cases where peripheral blood eosinophilia is there and you feel suspect pulmonary eosinophilia, normal chest X-ray, because CT is more sensitive in picking up. Some pattern recognition can be made with CT test. Of course, very few conditions have classical patterns. Workup for parasites, sputum, stools, serology, etc. In many cases, stools may be negative, so sputum, bowel, or serology may be required. Bowel, do a differential count as well as test for infectious agents, specific serology, and in cases where we can't make a diagnosis, maybe lung biopsy, other organ biopsy, peripheral smear, or bone marrow might be required in a small proportion of cases. Serological tests, strongyloids, ELISA is the crucial test. Ascaris, usually serological tests are not clinically useful at the time of PAE. Trichinosis, ELISA or other serological tests. Filariasis, testing for antiviral antibodies, that will be enumerated in the subsequent talk. Paragonimiasis, Echinococcus, cysticercosis, ELISA or immunoblot. Coccidioids, ELISA for IgM and IgG specific for coccidioids. CHURG-STRAUSS syndrome, P-ANGA. Allergic bronchopulmonary aspergillosis, total serum IgE and aspergillus specific IgE and IgG. So these are the serological tests that need to be done in undiagnosed pulmonary infiltrates with eosinophilia. Some specific radiological appearance, it might be helpful if there are specific radiological findings, and sometimes transient and fleeting findings also will help us to make a diagnosis of conditions like low flows or ABPA. Specific findings might be seen in ABPA, chronic eosinophilic pneumonia, and acute eosinophilic pneumonia. Non-specific findings is the norm in CHURG-STRAUSS syndrome, drug-induced syndromes, and parasitic diseases. So what to look for? Transient and fleeting infiltrates and patchy infiltrates or reticulonodular opacities. So this is a case of allergic bronchopulmonary aspergillosis. Here, the CT actually classically shows high attenuating mucus. The mucus density is much higher than that of the paraspinal muscle. So when this finding is there in an appropriate clinical setting, you have a very high chance of diagnosing allergic bronchopulmonary aspergillosis. Again, there was a leading bronchus which actually led to the mucoid impaction. So the diagnosis of bronchopulmonary aspergillosis was highly forthcoming based on this X-ray and CT. Again, another patient where large cystic central bronchiectasis and bilateral infiltrates. Now, this is a situation where we get peripheral infiltrates, pulmonary eosinophilia, peripheral blood eosinophilia. So this appearance has been termed as photographic negative of pulmonary edema. If it occurs in the characteristic patient, then probably we have a high index of suspicion for chronic eosinophilic pneumonia. Now, in this season, I would put it very simply that if we have a COVID-like X-ray and COVID-like CT, where COVID is negative and eosinophilia is there, probably think of chronic eosinophilic pneumonia. Role of bowel and lung biopsy. If a clear-cut cause of pulmonary eosinophilia is not evident from other tests, and if a clear-cut diagnosis is evident, then bowel may not be required, like drug implicated as the specific cause of PAE, or a parasitic or inflammatory condition is diagnosed from serological tests or other stool or lava or something like that, then a bowel may not be required at all. Otherwise, bowel helps us to determine the etiology of pulmonary infiltrates. Very crucial in situations where there is no peripheral blood eosinophilia, classically acute eosinophilic pneumonia, some cases of chronic eosinophilic pneumonia, etc., where there is no peripheral blood eosinophilia, but the bowel actually reveals significant, more than 25% bowel eosinophils. Again, to rule out alternate infectious causes as the cause of pulmonary infiltrates, classically tuberculosis, coccidioids, etc. For that, microbial tests of the bowel may be very important. So what all tests in bowel? The routine things that we do, AFP smear, MTB culture, or CB-NAT, fungal, bacterial, etc. Bowel TC and DC for diagnosing pulmonary infiltration with eosinophils. Microscopy for ova, parasites, etc. Malignant cells. These are the probable things that we require in our bowel. Interstitial infiltrates with bowel eosinophilia can occur in a lot of conditions. Mild to moderate counts, less than 25%, can occur in connective tissue diseases, drug-induced pneumonitis, fungal pneumonia, even in case of some cases of IPF. So a high count more than 25% is kept as the cutoff. for diagnosing pulmonary eosinophilia syndromes in BAL. Lung biopsy for causes of pulmonary eosinophilia other than infection, medication, or toxin. To establish and document the nature of the disease, lung biopsy may be worthwhile in selected cases. Again, I say very selected cases because this is challenging, it's costly, it's dangerous. So unless it's really worth, probably don't go for it. Otherwise, if you don't have a diagnosis, please go for it. Conditions like CHURG syndrome, acute eosinophilic pneumonia, etc., will respond very well to glucocorticoids. So a firm pathological diagnosis can be obtained from lung biopsy, as well as we really need to rule out any opportunistic infection, especially conditions like strongyloides and mycobacteria, coccidioides, etc., for which lung biopsy may be useful. And CHURG syndrome has the potential to involve multiple organs, and documenting vasculitis in biopsy specimens may be very useful in making a diagnosis of CHURG syndrome. I will just wind up with a few more slides, features of some selected pulmonary infiltrates with eosinophilia. Now, acute eosinophilic pneumonia is a very special entity because it has many peculiarities. First of all, it develops rapidly over a period of maybe few days, and rapidly progresses to acute respiratory failure in an otherwise previously healthy patient. It's often associated with recent initiation or resumption of cigarette smoking, or even sometimes heavy inhalational exposure to smoke, sand, dust, etc. Usually an acute febrile illness less than a week duration, non-productive cough, dyspnea, etc., which rapidly progresses to respiratory failure, at least in a minority of cases. The second challenge here is that you have a ARDS-like picture. Peripheral blood eosinophilia is actually lacking. May develop in the course, but usually in majority of cases, initially at presentation, peripheral eosinophilia is lacking. So this is a real challenge, and this is one situation where you really need bronchoscopy, BAL differential count, and other things to rule out alternate causes of ARDS for making a diagnosis of acute eosinophilic pneumonia, because once this patient actually mandatorily requires steroids, and if you don't give steroids, probably there is a very high proportion of patients who are not going to make it, but they have a dramatic response with steroids. So this is a condition where we really need to be proactive. So this is the classical radiology, sort of ground glass shadows and ARDS developing, and the biopsy shows infiltration of pulmonary parenchyma with a large number of eosinophils. BAL eosinophilia is classically more than 25%. In many cases, we get 50 to 60% BAL eosinophilia in this condition. Now, chronic eosinophilic pneumonia develops much more insidiously over a period of even weeks, predominantly occurs in women and non-smokers. Subacute illness characterized by cough, fever, shortness of breath, progressive shortness of breath, wheezing, etc. In many cases, there can be a new onset of asthma-like symptoms. Peripheral blood eosinophilia is common, but may be absent in around 10 to 20% of patients. As I said previously, the characteristic radiological appearance is the photographic negative of pulmonary edema. Again, BAL eosinophilia may be more than 25% in chronic eosinophilic pneumonia. CHURG syndrome is a multi-system involvement. Acute eosinophilic pneumonia and the chronic eosinophilic pneumonia are actually lung-limited conditions, whereas hypereosinophilic syndrome, CHURG syndrome, etc., are multi-system conditions. So it is also the real term is eosinophilic granulomatosis with polyangiitis. CHURG is a probably a commoner terminology, but the real terminology to describe will be EGPA, or eosinophilic granulomatosis with polyangiitis. Usually we have a preceding asthma, sinusitis, extrapulmonary manifestations classically like mononeuritis multiplex, etc., and multiple tissue infiltration with the eosinophils. In addition to the lung, skin, cardiovascular system, GI, renal, many systems can be affected. Often 40 to 60% of cases, P-ANGA or ANGA to myeloperoxidase is positive, which actually aids in a diagnosis if there is a proper consistent clinical history and findings. And extravascular tissue infiltration by eosinophils is very common, and that clinches the diagnosis of CHURG syndrome in the appropriate setting. Hypereosinophilic syndrome is again similar. It involves multiple organs, but by and large, it's a diagnosis of exclusion. Even bone marrow infiltrations with eosinophils do occur. So with this, I come to an end of my topic. Again, targeted therapy will depend upon what is the cause of pulmonary eosinophilia. If it is parasitic or helminthic infections, specific anhelminthics will be the order of the day. If it is a drug-induced pulmonary eosinophilia, withdrawal of the culprit drug. If it is life-threatening or the eosinophilia doesn't clear, probably a short course of steroids. In conditions like chronic eosinophilic pneumonia, acute eosinophilic pneumonia, CHURG, STRAUSS, hypereosinophilic syndrome, etc., steroids are the mainstay of treatment along with other immunosuppressives if there is a steroid refractory disease. Some of the hematological malignancies, including the lymphomas, can actually present with pulmonary infiltrates and eosinophilias, in which case proper diagnosis and directed therapy will be the norm of the day. So if I can just summarize, eosinophils are predominantly tissue cells, and a lot of eosinophilic infiltration and tissue damage can occur. Pulmonary infiltrates with eosinophilia is a common condition where we need pulmonary infiltrates in a chest radiograph or CT chest and peripheral blood eosinophilia. If we really need to demonstrate lung tissue invasion, a biopsy or a BAL differential count may suffice. A focused drug history, look for parasitic infections and neoplasms as causes. Serology and specific chest X-ray or CT findings may be useful. In unresolved cases, BAL and lung biopsy may be useful, and targeted therapy is the norm of the day. Thank you.
Thank you, Dr. Rajesh. Thank you very much. It was an overview, very wonderfully presented. And are there any questions from the audience? Those who have, hello, okay, right. Are there any questions?
Yes, sir, there are a few questions.
Okay.
Yes, sir. So the first question is, allergic rhinitis and huge eosinophilic count, what is the approach to it? I mean, how to approach such kind of observation?
Okay. Shall I take it?
Yes, please.
Yeah. As a general rule, you do get some eosinophilia in allergic rhinitis and asthma, but not to the tune of very huge. I don't think we have a specific cutoff like that, but then if you see more than say 20 to 25% eosinophils or an absolute eosinophil count of more than 1,500, that's probably the time that you start to think whether there is something else to that other than a simple asthma or allergic rhinitis. Again, allergic bronchopulmonary aspergillosis is one thing that probably we need to rule out. Many of the pulmonary eosinophilic states that we saw, chronic eosinophilic pneumonia or CHURG syndrome, many of them to begin with have an asthma-like presentation, new onset asthma, wheeze, etc. So it may be prudent to rule out these conditions if we see disproportionate eosinophilia, and that too consistently in 2-3 samples. I don't have a very clear-cut cutoff as to when you should, but on an average, anything less than 10, I would just leave as such. Anything more than 20 on 2 or 3 consecutive occasions, I probably would have a trigger to investigate further, despite simple treatment of asthma with your inhalers or sustained with theophylline or montelukast or something like that. Still, your eosinophilia doesn't move away, or the disease is progressive. That would be the trigger for me to evaluate further.
Right. Thank you. That's one. I just want to add regarding this question. There's another marker we can always try. That's IgE. If the IgE is not terribly high, if it's around less than 1,000 or just about 1,000, and the X-ray is pretty clear, then think of asthma with allergic rhinitis. If the IgE is extremely high, more than 3,000, and the X-ray shows nodular infiltrates or ground glass opacities, then you have to think of something, as Dr. Rajesh has said, something more than just simple asthma and allergic rhinitis. Right. Any further questions? Okay. So I think
there is one more question. I think there are 3 questions in total.
Okay.
So should I read it out right now?
Yes, please.
So the next question is the role of HRCT in eosinophilic pulmonary syndrome diagnosis.
I think I just elaborated that in my lecture, but then to be very short and precise, it has a role where you have peripheral eosinophilia, you are suspecting pulmonary eosinophilic syndromes and have a normal chest X-ray. So you might find infiltrates that are not there in the chest X-ray, one. Secondly, you have some reasonably specific patterns in a few conditions of pulmonary eosinophilia, like allergic bronchopulmonary aspergillosis or chronic eosinophilic pneumonia, some cases of acute eosinophilic pneumonia, etc. So in such cases, you might have a etiological clue from the HRCT. I think that's probably it.
Right. I think we should just carry on. The questions will be more, but I think there's we've just crossed the half an hour. And we have to go ahead for the next speaker, tropical pulmonary eosinophilia. Thank you, Dr. Rajesh.
Thank
It
you.
was wonderful.
Thank you.
Now, may I welcome Dr. Ajmal Khan, Additional Professor, Department of Pulmonary Medicine, SGPGI, Lucknow. And he's going to talk on revisiting tropical pulmonary eosinophilia. Dr. Khan, please.
Thank you, sir. I especially thank Dr. Partha, sir, for inviting me for such a topic which is not routinely considered by the young generation. And I can say that even the older generations are not so tuned of this tropical pulmonary eosinophilia. That is why I have mentioned that there is a need to revisit it. So I will, because tropical pulmonary eosinophilia is not commonly seen, many of us do not consider it into the differential diagnosis. However, because of the excellent connectivity between the cities and the countries, now the peoples are going here and there very fast. So people who are from the endemic countries are also visiting in a newer places in the search for a job or something else, for a new home. So those people mandate it now to consider the tropical pulmonary eosinophilia, especially if the eosinophil counts are very high. So I will start with the case scenario. This is a 24 years old male who came to us from a Judea. He was a medical student and he was doing his MBBS from Allahabad. So he presented with a cough, dyspnea, and wheezing. There was no seasonal variation. However, there was a diurnal variation. More symptomatic. He was more symptomatic during the night, and on physical examination there were rhonchi. So at presentation, his PFT showed there was an obstructive defect, but there was no bronchodilator reversibility was there. So when we evaluated him, he has a eosinophil count of 960 only. However, the only clue was that he was a filarial antibody positive. So we continued to follow him. And after 3 weeks, when we repeated, the eosinophil count remained the same, but we had just given him anti-allergic drug, nothing else. So we followed this patient for another 3 months. And what we see is that AEC count was decreased slightly and his symptom continued. Then after 6 months, he had a sudden rise in eosinophil count to almost touching 3,000. And then at that point, we have given the diethyl carbamazine at that time in the doses of 6 milligram per kg body weight. And after that, there is a rapid decline in eosinophil count, as well as he became asymptomatic. After he became asymptomatic, he continued to be in our follow-up, but now he was looking for the patient of tropical pulmonary eosinophilia because he joined the Department of Pulmonary Medicine in SGPGI, and currently I think he is one of our audience as well. He was working with us for 3 years as a senior resident. Now he has joined outside as a consultant. So the highlight of this case was that maybe initially the counts may be low, but if we continue to follow these kind of a patient, there is chance that this patient will have a acute rise in eosinophilic count. So another patient was that 31 years old male from Lucknow. He was a student. He presented with cough for 2 months, dyspnea 3 months, and wheezing with diurnal variation. There was no seasonal variation. Physical examination, he had a rhonchi as well as crepitations. So he had an obstructive defect as well as there is a decrease in TLCO. So this was the HRCT of the chest, which shows diffuse nodular infiltrate in a randomly distributed nodules were there on the HRCT involving the whole of the lung. So we have evaluated, and what we found is that eosinophil counts were 23,000 out of the total count of 26,000. He was filarial antibody negative. So we admitted this patient for further evaluation, and during the subsequent days, more or less the same count we encountered the more or less same absolute eosinophilic count, and at one occasion it was almost 43,000. And on subsequent day it was 46,000. So we have given a dose of diethyl carbamazepine at that DEC at that time, and what we found is there is a rapid decline in eosinophil count. But because we have not evaluated this patient for further etiologies we have worked up before that I will come subsequently. And what we found is that subsequently his eosinophil count has come down to less than 1,000. During the workup, he was also evaluated for primary or clonal eosinophilia with PDGF alpha and beta, which was negative. He also underwent bone marrow biopsy, which shows there is only hypereosinophilia. No other abnormalities were there. BCR ABL real-time PCR was also negative. So we performed the transbronchial lung biopsy as well in this patient before we starting the treatment. And what we found is that among the that histopathological picture, nicely filaria was sitting inside the lung tissue. So the diagnosis was confirmed and he was started on treatment. And after the treatment, after 3 months of that treatment, this was the CT which shows there was a marked improvement in the nodular infiltrate of the chest. So we will come to the another case, which is a 43 years old male, was a carpenter who presented with a cough, sputum for 4 months and dyspnea for 6 months. There was a diurnal variation, no rhonchi. However, there was a coarse crepitation, who was treated as asthma with inhaled medication from outside. So on the basis of this total raised IgE count as well as Aspergillus specific IgE count, he was diagnosed as the ABPA and he was subsequently started on steroid treatment. However, this was the initial eosinophil count when he presented to outside. So when there was no symptomatic improvement with the steroid outside, he took for it for almost 4 weeks. And after that, he presented to us. So we repeated the specific IgE as well as total IgE. And this time we have also repeated the specific IgG, which clearly shows that the specific IgG was not raised. So it was not a patient of allergic bronchopulmonary aspergillosis. And when we did the hemogram, what we found was the out of the 26,000 total count, he has 18,200 eosinophil count, which is after the 1 month treatment of high dose of steroid, 1 milligram per kg body weight of steroid. So it has decreased from 21,000 to 18,000 only. So at this moment, we have started this patient. We have evaluated this patient and found to have filarial antibody positive. And then we have given the course of DEC. And subsequently, he became asymptomatic and his eosinophil count has almost vanished. So, and after the treatment, this is the total IgE that has initial total IgE of almost 30,000. It has come down to 1,350, and specific IgE has also come down from 2.37 to 0.56 with the treatment of DEC only. So basically, tropical pulmonary eosinophilia was described in 1940 not as a tropical pulmonary eosinophilia. It was described as a pseudo tuberculosis, because in a tuberculosis sanatorium, what they have found is when they evaluated the X-ray of the patient, there were a lot of patients who had a chest infiltrate, and what they found is there was among these almost 600 patients has a raised eosinophilic counts. So the highest count they have encountered were 85,000, 48,000, 47,000, and 42,000, and the highest eosinophil percentage was 92%. So these patients, 179 among the 561 patients, those with the highest number, 179, who were admitted with less than 20% eosinophil count, but who had an eosinophil count above that figure during the treatment, all with less than 1,000 eosinophils, and majority of these with 1,000 and 2,000. So they were admitted with less than 20%. So they were not given any kind of a treatment. Similarly, so what they have defined is the above case histories make it clear that we have to deal with a lung condition which cannot easily be classified under the most common chronic lung affections. So they have not treated this patient and they have continued to follow the patient. And what they have found is a further study of these conditions shows that these patients had a good response, good prognosis as judged by the discharge results. And after discharge, after histories beyond what could have been expected had that the condition been tuberculosis. So they have defined it as a pseudo tuberculosis in 1940. At the same time, in 1943, Dr. Win Garden, who was working as a physician for the British government in Indore, he collected a lot of patients. Since 1934, a complex of symptoms has been frequently been seen, which constitute a new disease entity apparently peculiar to certain parts of India. His opening words were like this. So what he has done, most of these cases had been previously diagnosed and treated either as pulmonary tuberculosis or chronic bronchial asthma. And this is quite true till now. And what he mentioned, that the peculiar condition of consulting practice in India, where patients do not continue to attend when they are relieved, made it impossible to follow up these cases at all closely. So in summary, he has defined it as a new disease. It is described, characterized mainly by severe spasmodic bronchitis, leukocytosis, and very high eosinophil count. It has no relation to any other disease, particularly not to tuberculosis. At that time, the etiology of filaria was not established. So he defined it as a just tropical pulmonary eosinophilia. And interestingly, during the follow-up, one of his patients has acquired syphilis. And at that time, the treatment for the syphilis was arsenic compound. So he has that patient was treated with this arsenic compound. And what surprisingly Dr. Wingarden has encountered was that eosinophil count has rapidly came down. So for almost 20 years, this arsenic compound remained the main treatment of choice for tropical eosinophilia. So the association of tropical pulmonary eosinophilia with filariasis was established, or it was assumed, because there was a close association with filarial endemicity, and there is a demonstration of microfilaria from the lungs. There is an elevation of filaria-specific IgE and IgG, and positive results were found with leukocyte adhesion phenomena, basophils releasing greater than histamine when challenged with Wucheria bronchiopty antigens. And there was a prompt response with diethyl carbamazine. So in 1953, the treatment of eosinophilia, lung tropical eosinophilia with diethyl carbamazine has been started by Dr. Dhanraj, and he does a study in almost 110 patients with tropical pulmonary eosinophilia in a dose finding study of DEC. And he has treated almost 110 patients with, and what he found was, there was, after the dose of DEC, there is a rapid decrease in eosinophil as well as leukocyte count, and patient becomes symptomatic within a week of treatment with DEC. So in 1964, Donoghue has given a criteria to diagnose the tropical eosinophilia, the major criteria and the minor criteria. The major criteria was the pulmonary symptoms with nocturnal cough and dyspnea, eosinophil counts over 2,000, preferably more than 4,000, and filarial complement fixation test positive, and response to DEC. These are the four major criteria. And minor criteria: resident in an endemic area for several months, illness in young adult male, rhonchi and crepitation, chest X-ray showing diffuse military mottling, raised ESR, and non-specific symptoms of fatigue and weight loss. The tropical pulmonary eosinophilia was diagnosed when all four major criteria, but if any one is absent, at least three minor criteria were present. So after these criteria were established in 1964, there was a flooding of data from the Indian subcontinent. Approximately 200 papers has been published, but among those 200 papers, only the numbers of the tropical pulmonary eosinophilia patients were increased, because it was only a descriptive study from multiple centers, 20 patient, 50 patient, 80 patient, 110 patient, like this. However, nobody has done any useful exploratory study on the tropical pulmonary eosinophilia, except in 1990s, where Dr. Vijayan has started exploring some aspect of tropical pulmonary eosinophilia, and he has shown that pulmonary membrane diffusing capacity and capillary blood volume in tropical pulmonary eosinophilia, where he found that tropical pulmonary eosinophilia patient will ultimately lead to fibrosing lung disease with decreasing DLCO if not treated early in the course of their disease. Similarly, there is he also studied that correlation of lower respiratory tract inflammation with changes in lung function and chest X-ray in patient with untreated tropical pulmonary eosinophilia. Effect of diethyl carbamazepine on alveolitis of tropical eosinophilia. These are some experimental studies that he has performed. And after that, there is a halt in the publication of tropical pulmonary eosinophilia. And almost the last paper, if I say, it was almost maybe 20 years back for in tropical pulmonary eosinophilia. So this is the approach to peripheral blood eosinophilia. When we encounter, now the question is, when we say it is a peripheral blood eosinophilia, if we take it more than 500, absolute eosinophil count of more than 500 is defined as a raised peripheral blood eosinophilia. However, if we consider the British thoracic guidelines, the British hematology guidelines, they say that until the patient have a more than 1500 absolute eosinophil count, they do not require any kind of a evaluation. So we have divided this. This is our approach at our institute, that what we do is, whenever we encounter absolute eosinophil count of less than 500, we normally take a proper history for drugs exposure, skin allergy. We perform the stool examination, peripheral blood smear, filarial antigen and antibody, microscopy for the microfilaria, IgE, and aspergillus specific IgE. And after this, there is no further evaluation, and symptomatic treatment is given, and follow-up observation is being done. If the eosinophil count is more than 1500, evaluation of the etiology was undertaken with echinococcus serology, vasculitis workup, PDGFR, alpha and beta examination, chest X-ray, ECG, pulmonary function test, diffusing capacity, bone marrow examination, CT thorax, and BAL, TBLB, and EBB, depending upon the case scenario. It is not that all patients will go all these investigation. Depending upon the history as well as the clinical findings, we perform all these investigation. And if no etiology is found and absolute eosinophil count is more than 200 or more and fulfilling the criteria for TP, these patients are diagnosed as a tropical pulmonary eosinophilia with a differential diagnosis predominantly of pulmonary manifestations are Lafleur syndrome, chronic eosinophilic pneumonia, bronchopulmonary aspergillosis. Predominantly systemic manifestation or both are the hypereosinophilic syndrome, vasculitis, drug allergies, and some parasitic infections. So at our center, totally we have almost evaluated 300 patients of eosinophilia, out of which we have found etiology in 34 patients, of which 7 were the drug exposure. Stool was positive in 18 patients. Echinococcus serology was positive in 3 patients. There was 4 patients of vasculitis and 2 patients of hypereosinophilic syndrome. No etiology was found after extensive workup in 261 patients, and these patients were diagnosed as a tropical pulmonary eosinophilia. I have break up this 261 patient into 248 plus 13 because all the 13 patients which when they presented, they were not fulfilling the criteria as given by the Donoghue for tropical pulmonary eosinophilia, but subsequent in follow-up, they have fulfilled all the criteria and being treated with DEC 6 milligram per kg body weight, 3 weekly course depending upon the response of the patient. So among the 248 patient, majority of the patient were in the group of 20 to 50 years, and there was a predominance of male gender. Approximately 80% of the patient profile were male. And cough, dyspnea, and fatigue were the main symptoms in clinical scenario, and there are significant, that is almost 70% people had a diurnal variation. So if you see the median count was 14,000 and absolute eosinophil count was median count was 6,000. IG was 3,000, specific IG was 0.31. Filarial antigen was positive in almost 40% of the patient. Filarial antibody was positive in 90% of the patient. On microscopy, we have found microfilaria in 6 patients. We have performed TBLB in 55 patients where either that filarial antibody was negative, or there was some doubt about the etiology, and majority of them have tropical pulmonary eosinophilia. 24 patients underwent the bone marrow examination. Among the treated patients, on the results after the 3 weeks, there was a cure in 129 patients, out of which 20 patients relapsed after 3 weeks of treatment. After 3 weeks of treatment, 119 patients remained asymptomatic, and there was a persistent rise in eosinophils. So they required longer duration of treatment, maybe 6 weeks, maybe 3 months. So among them, 13 patients were relapsed. We defined the relapse as the eosinophil counts has come down to less than 1,000, as well as patient has become asymptomatic for minimum of 6 weeks. And after that, if he had a reappearance of symptoms, we defined it as a relapse. So total relapses was 33. And the relapse duration ranged from 3 months to 42 months. So ultimately, after the dose of DEC, there was cure was achieved in 100% of the patient. DEC course was given for 3 weeks in 129 patients, and 6 weeks for 99 patients, and 3 months for 3 months in 20 patients. And the follow-up was ranging from 4 months to 71 months. So this is the FEV1 pre versus post treatment, and we see there is a slight increase in improvement in lung function, which is the treatment after 3 months of DEC. And if we see, there is a rapid fall in absolute eosinophil count after the treatment with DEC, and this is follow-up of patient of 28 patient who has an initial very high AECA count, and which showed initial increase in eosinophil count after the treatment was started for with DEC, and then after that there was a rapid decline. Similarly, if you see, there is a steep fall in IG levels as well as specific IG levels. So TP on follow-up of 13 patients, they were minimally symptomatic. AEC was less than 2,000 at baseline. Filarial antigen was positive. Symptomatic treatment given and followed up regularly with AEC and or IG level. And we on this graph, you can see those 13 patients, there was no treatment was given at baseline, only treated with when AEC was 2,000 or more. You can see the absolute eosinophil count in those patients who are initially eosinophil count were less than 1,000 has gone up to the 6,000. So in conclusion, tropical pulmonary eosinophilia is not rare in endemic area. It is a diagnosis of exclusion. Diagnostic criteria needs revision because it needs to be included the patient who present with less than 2,000 of eosinophil count, and definitive test is required to confirm the diagnosis. With this, I conclude, and I welcome any question on this rare disease topic.
So we will have the question answer session at the last. So we can continue with our next speaker.
Right. Okay. That was excellent, Dr. Khan. And we will move on to the next speaker. We'll take the questions later.
Okay, sir.
And we now have Dr. Ongira Dasgupta, who will be talking on aspergillus and fungal disease and airway disease and eosinophilia. Dr. Dasgupta, please.
Good evening. Oh,
Good evening.
my slides, please. Yeah.
I think the slides are.
The moment I share my slides and put it
Till
on.
you share your slides, can we just? Is it going to take time,
No,
madam?
it's fine.
No, that's there. Okay.
So at the outset, I thank Parthoda for the invitation, and thank you, Shubhashida, for being the chair. This topic, airway diseases and aspergillus, is a topic which, with the beauty of not having changed for a very long time now. So whatever we knew around 10, 15 years from today almost seems to be the same with just subtle differences. Oh. Is there some, can't move on. I'm sorry. Okay. So the objectives of my, I'll keep it like this because the moment I put in slide share, I cannot make a progression of the slides. So I will. Okay. So the objectives of my talk today would be to discuss the spectrum of aspergillus lung disease, try and give a sense of what is sensitization and what is allergy, very briefly touch on the diagnosis and principles of treatment, and I hope to put all this in the clinical context so that we have a sense of what we do, how we manage and how we work up aspergillus lung diseases. So my first case is that of a 50-year-old male who's in hypertensive on regular medications, had exertional dyspnea for 6 months, was allergic to dust, smoke, had rhinitis and very frequent itchy eyes. However, he denied a history of having pets or birds at home. On clinical examination, we really did not have much to say, excepting that he had very small nasal polyps, minimal pedal edema, blood pressure of maybe borderline raised, chest, normal breath sounds. This is what the chest X-ray looks like. I think it's normal. The spirometry, yes, there is obstructive airway diseases with reversibility. So this fulfills our definition of asthma. So what do we do now? This is what came into my mind. Should we do a blood work with the total IgE levels, eosinophil specific IgE for common airway allergens? Start off with treating the patients like we usually do with inhaled corticosteroids and long-acting beta-2 agonists. Should we go ahead and do a sputum quantitative assay or maybe a skin prick test? Now, I think these are all legitimate options that we could all use in maybe change it in our own priority list. The total IgE in this patient was 450 international units per liter. So one thing to point out is that the units might be different from one lab to another. So when we interpret the results, we should pay very importance. We should be giving very good importance to the international units per liter or KUA per liter. So these are some of the various units that are seen in X-rays. The aspergillus specific IgE was elevated. So what is the diagnosis of this patient? Patient has a reversible airway disease with a raised IgE, although not to that great extent, but yes, it's raised. Aspergillus specific IgE was raised too. So this is one of the cases where we call the patient's disease to have Aspergillus fumigatus associated asthma, AFAA. Nothing much needs to be done, as is quite evident from the clinical presentation and the investigations. We just simply follow our usual asthma guidelines. So what is AFAA, the patient has controlled asthma, has elevated Aspergillus fumigatus specific IgE, and the total IgE is raised but less than 500 international units per ml. So that's the definition. Now, the pathophysiology of the fungal asthma patients is similar to that happens in all patients with allergic asthma. And why is it so? Because Aspergillus is ubiquitous in the air, it's present everywhere. And the beauty of Aspergillus is that it is one of the pathogens that can grow in the body in our own body temperature. So it just keeps sticking on to the body. Now, I do not want people to go through this slide, but this is just to show that Aspergillus behaves just like one of the allergens that can precipitate asthma. So the red, can you see my cursor there? The red oval thing is an allergen which goes inside the airway mucosa by a breach of the epithelium, and it stimulates the differentiation of a naive Th cells, which can be transformed into a Th2 or a Th1, or maybe one of the interleukins can precipitate the formation of mast cells from plasma cells, and the play just goes on. Now, why is it important to know that there is a raised Aspergillus spore count in the air? Now, this is what is done not in India, but in the West. So they have found that if you had a raised spore counts of asthma, raised spore counts of Aspergillus, the asthma attacks and admission to hospital rates go up. So reason to know what the Aspergillus spore count in the air really is like. This takes me to the second case, which is a 45-year-old gentleman, symptomatic since 14 years of age. He's an engineer, a never smoker, visits construction sites occasionally, and he vouches that he has always used personal protective device whenever he goes into the construction sites. He had been having these cough, scanty expectoration, and wheezes since the age of 17 years, was diagnosed as asthma clinically, started taking inhalers since his teens, has frequent episodes of rhinitis, but he could not tell us what allergies he actually had. Presently, he had a low-grade fever, streaky hemoptysis since November 2000. This is an old patient, so November 2012. A lot of expectorations in a year, 3 of them, but responded to steroids in all the occasions. And the good thing with him is that he did not have any history of hospitalization. What about the spirometry? Obstructive disease, but only partially reversible. Blood work, eosinophils 3%. IgE is here, it may be noted that it's more than 527, that's more than 500. And here are the CT scans. Okay, so I hope it's visible. A lot of bronchiectasis and tree in bud appearances in both the lung disease, in both the lungs and in all the lobes. A closer look, yes. So when we did an allergy panel, which included the specific IgEs of the fungi that we suspect in our situation, it's raised in all of them. So nothing specific about Aspergillus here, but when Aspergillus is associated with other fungi and can precipitate asthma, it becomes severe asthma with fungal sensitization. So the last time we had asthma, which was Aspergillus fumigatus associated asthma, this one is severe asthma with fungal sensitization. This is another form of fungal asthma, and the criteria for diagnosis that has been laid down by Denning is that a person usually has severe asthma and not the controlled one like the last AFAA definition. The total IgE ranged from 500 to 1,000, that's more than 500, but less than 1,000. Elevated Aspergillus fumigatus specific IgE and normal Aspergillus fumigatus specific IgG. So this is the definition of SAFS. Now, what is the difference between allergy and sensitization? Sensitization means that you have an elevated IgE of the certain agent that you are looking at, but there will be no symptoms, tissue damage or exposure to that agent. And what's allergy? You are supposed to have an exaggerated immune response rather than a pathogenic pharmacological or toxic property of the primary agent. So the fungus does not contribute directly. It just has a immune response which is exaggerated in nature. So that is the difference between allergy and sensitization. However, sensitization can evolve into allergy depending on the person's cofactors present, on the level of exposure, and etc. How do we treat SAFS? It's similar to asthma. Only thing is there has been a suggestion that one could use antifungals in cases who do not respond to the usual treatment. And although we do not have any definite guideline on that, a case series has been reported. And of course, you could consider giving an anti-IgE omalizumab. But again, there are no straight studies to demonstrate its usefulness. This brings me to the last case. This is that of a 61-year-old lady, an office clerk, non-smoker, symptomatic with wheezes and shortness of breath since childhood. He has been having cough, scanty expectoration, and wheezing for the past 22 years. That's a very long time. Diagnosed as bronchial asthma clinically, has been on oral medications, had to take ATD twice, and started taking MDI since the past 20 years. And this patient told us that he was allergic to dust and cotton. Current symptomatology, low-grade fever since December 2012. Exacerbation rates were again pretty high, 3 to 5 exacerbations per year. And what was wonderful for her is that the response to oral corticosteroids was always very good. This patient needed an hospitalization thrice per year, but never intubated. This is her spirometry. We had partially reversible severe airflow obstruction, suggestive of severe asthma. This is the initial chest X-ray. A lot of infiltrates, I think, on both lungs and all over. Blood work, eosinophil counts on the rise, but tuberculosis was excluded. Chest X-ray, more infiltrates, making it almost very dense. IgE 3641. Skin prick test, positive for, again, Aspergillus here. The only other fungi that the patient was allergic to was Alternaria. The remaining were all Aspergillus species. Here's the CT scan. Extensive disease, extensive bronchiectasis, terine bud appearance, mucus impaction. Just name it and you'll find it in the CT scan. A bronchoscopy was done some time earlier, which was normal, not very bad or very good. Allergy panel, yes, you can see Aspergillus fumigatus specific IgE was very, very raised, making a diagnosis quite easy in this case. The diagnosis was allergic bronchopulmonary aspergillosis, right? So now how do we diagnose ABPA? So criteria has been laid down. You could have an ABPA-S and an ABPA-B. Both of them are almost similar with a total IgE of more than 1,000, eosinophil count of more than 500 cells per microliter, a raised Aspergillus fumigatus specific IgE, elevated Aspergillus fumigatus specific IgG, transient or fixed pulmonary opacities, and the only difference between these two groups is that the S group had a normal HRCT chest, whereas the B group had bronchiectasis. Coming to the principle of treatment, of course, avoidance of fungal exposure. A lot of anti-inflammatory agents should be given, and the way I usually do it is that to understand what the minimum dose of steroids the patient really requires, I try to titrate it against the sputum or the blood ears. Do we need antifungals? Yes, we need antifungals in ABPA just to reduce the fungal load. And we could use itraconazole, voriconazole. People have also tried nebulized amphotericin B. The role of omalizumab still remains unclear because these patients have very, very high IgE, which is beyond the dosing schedule of omalizumab. This is an interesting study which we had done way back in 2013. We took the sera from patients who were treated with rituximab for lymphoma. And then this was a double-blinded study which they had done to see the effectiveness of rituximab in lymphoma. And we took the steroid from them and worked out the serum Ig levels at baseline 3 months and 6 months. Yes, there was a trend where rituximab did work, but again, this needs to be verified in bigger clinical trials. What about Aspergillus vaccines? Do we really have something in the future like the COVID vaccine? Apparently, there are a lot of Aspergillus vaccine candidates, but the problem is that there is significant homology to the human proteins, and thus the selection of the protein against which the antibody will develop and the antibody which we will be using as a vaccine is not yet very clear. There are several potential antigenic proteins, and possibly there's a big heterogeneity between individuals. There are a few success stories only in animal models, and the search is still on. So now this gives a comprehensive view to understand that if you have an Aspergillus in your body, in your airways, it depends completely on the microbial host interaction, your level of immunity in your body, which will decide the way your body is going to react, or rather the Aspergillus is going to behave with you. If you had an immunodysfunction, then you could end up having invasive aspergillosis or subacute invasive aspergillosis. If you're immunocompromised, but not to that extent, it would be colonizing by Aspergillus, aspergilloma, or chronic pulmonary aspergillosis. And if your immune system had an hyperactivity response, then we would have ABPA, severe asthma with fungal sensitization, allergic sinusitis. Again, a different way to explain why we do have asthma. Certain patients have asthma sensitization only, whereas certain patients have an invasive disease or sometimes ABPA. This is because if the allergen, if the Aspergillus comes into the airways and your mucociliary clearance mechanism is working well, then the Aspergillus fungi just gets thrown away into the environment once again as you cough and clear your mucus. But if the mucus layer is abnormal, if the mucus layer gets bigger, thicker, as you can see in the middle panel, then the Aspergillus will just keep sticking on to your airways. And that is when it will cause either an invasive disease or maybe just a sensitization. It depends on, again, the immune system of your body. So this is the spectrum. If you are a normal person, efficient clearways, nothing. Immunocompromised host, infection, invasive aspergillosis. If a infection or colonization, in case of a cavity lung, that's an aspergilloma. Necrotizing pulmonary aspergillosis. And the last one is if you have an infection with an asthma background, then you could have ABPA or SFAS. Now, if you look for SAFS, that is severe asthma with fungal sensitization, you could end up with very large numbers, like this publication in Parthadas Pulmophase showed. Almost 41.1% had SAFS, that's severe asthma fungal sensitization. ABPA was present in 23%, while the others were 16 and 19%. So in summary, manifestations of diseases by Aspergillus depends on the immune system response. Clinical classification means Aspergillus fumigatus associated asthma. You could have severe asthma with fungal sensitization, ABPA-S, ABPA-B. Treatment principles are similar: optimized dose of steroids, antifungals if the load of fungus is quite high. The role of anti-IgE still needs to be explored, and research is needed for patients with IgE levels of more than 1,500 international units per liter. Thank you very much.
Thank you, Amrita. Thank you. And especially again for keeping to time. And do we have any questions? We have questions, if any, for Dr. Khan and Dr. Dasgupta, please.
So we have questions which we haven't taken in the previous sessions also. So this is the these are the questions in general. So I would like to ask. First question is, what parasitic work up and when? And what is the role of sputum eosinophil count measurement?
I presume I have to take that.
Yeah,
Yes.
yeah, sure, sir.
Yeah. Okay. Now, which parasitic workup will primarily depend upon what is endemic in the locality that you practice? I think that's the way to put things. But then the common things that we come across would be tropical pulmonary eosinophilia, Loeffler syndrome, where you get ascaris and ancylostoma and all those things. If you are in an endemic scenario, then schistosomiasis, then clonorchis, and maybe strongyloids. I would just request everyone to rule out strongyloids because most of the other things are actually conditions where most of the other pulmonary eosinophilias, including the acute eosinophilic pneumonia, chronic eosinophilic pneumonia, surftos, all those things, all of them are actually conditions where you require steroids. Even in conditions like tropical pulmonary eosinophilia and Loeffler's, although not the treatment of choice, steroids might help in symptomatic benefit. Whereas strongyloids is one condition where if you really give steroids, then you can have an overwhelming infection, even ARDS, systemic infection, and death, hyperinfection syndrome. So probably if you are in a endemic scenario, rule out strongyloids, and the best thing would be to do a BAL and look for those larvae and all those things. So I think summarizing what I said, depends upon the which parasite will depend upon the scenario that you are practicing, and then the common things will be tropical pulmonary eosinophilia, Loeffler's, strongyloids, etc.
Yeah, thank you. And I think with the COVID situation, a lot of people are on ivermectin, so we'll get rid of quite a lot of strongyloids. Okay. Right. Any other question? All right. I have a question for Dr. Khan. Dr. Khan,
Yes,
can
sir.
you hear me?
Yes, sir.
Right. You presented a very good study of around 250 patients, out of which 50% roughly did not respond within 3 weeks.
Yeah.
Is that correct? So is there any biomarker or any physical characteristics of this patient who will take a longer time? And is there any role of doxycycline on these patients in addition to DEC?
No, actually, what we have seen is there, sir, that majority of the patient, the maximum number of cycles, that 3-week cycles of DEC was required was 3 only. So majority of the patient have responded well within a 9 weeks of treatment of 9 weeks is the maximum duration that is required in our patient, and 100% of the patient has responded to DEC treatment. And it is a cheap drug and it is almost side effect free drug. So means continuing the once the response has not seen within 3 weeks, there is no as such biomarker which will tell you that which patient is going to respond or which is not going to respond, because not a lot of work has not been done in this tropical pulmonary eosinophilia. And it is only the IG labels as well as AEC labels which defines whether and the clinical response, clinical symptoms, whether it has vanished or not. And the other thing is some people has a relapse. So in endemic area, if they continue to have an exposure with an antigen, that might be one of the reason which led the people to go into relapse rather than the disease itself, the continuing exposure of the antigen.
Right. Okay. So your main treatment focuses on DEC alone.
DEC only, because in few of our patients, the steroid has been started from outside. And what we have seen is there is a little or no response with the steroid in these patients.
No role of doxycycline?
As of now, we have not given the doxycycline to any of our patients.
Oh.
Yeah. So I cannot say whether it has any effect or not.
Right. Okay. Any other question from the
Yes,
audience?
sir. Sir, next question is for Gupta. How to measure the fungal load in Aspergillus lung disease to decide antifungal? And the DEC is commonly prescribed by GPs. It may be that TPE is not that uncommon. Dr. Dasgupta, please.
So the first question was
The fungal load, I think.
fungal load. Okay, so
Voice
What I really mean by fungal load being high or low is
Ma'am,
by the serum IgE levels. So if the serum IgE level is more than say 100 or 1500, that's when you have a high fungal load. So we don't measure fungus, we just measure the response, that's an IgE.
Right, yes. What was the other part of the question, madam?
DEC. Okay, so
yes, ma'am. DEC is commonly prescribed by GPs. It may be that TPE is not that uncommon.
you may be right in saying that, or whoever framed the question, but Shubhajita, should I repeat the question?
No, actually,
I understand.
I think the question was raised rightly, because majority of the patient with eosinophilia, they are being right and left, they are being prescribed with DEC without being worked up. So
No,
that's
that's fine.
yeah.
The next part, I think. What was the other part?
the
That
DEC
whether or
was
not
prescribed by
DEC,
GP.
empiric DEC would be helpful or not.
Ma'am,
That's
the
what
other
question
part is DEC is commonly prescribed by GPs. It
That's
may
all
be
right.
that TPE is not that uncommon.
Okay.
So
PPE. Okay. I didn't
given
hear
the
that.
fact,
PPE.
so it's given the fact that tropical pulmonary eosinophilia has a bigger prevalence in our country, empiric DEC is often prescribed by the GPs. So I wouldn't suggest that. If you have tests available, just go ahead and test them, because any drug given empirically without proof might be potentially toxic.
Right. Okay. Any more questions?
So there are many. So
I think we've already crossed the 30 minutes. I don't know if Dr. Parthoda is there.
Yeah, you can continue.
Take a couple of more questions. Shall we conclude the session? Because the talks were excellent and the answers are pretty well. We've answered quite a lot of questions.
I have a question for Dr. Rajesh. So,
yes, please.
Yes, ma'am, please.
You've been discussing a lot about doing a bronchoalveolar lavage. So do you really do them in your asthma patients when in trouble, or something else?
Sorry, ma'am, your voice was breaking.
Okay, so the question is, you've been talking about doing a bronchoalveolar lavage fluid examination to prove that the patient had airway eosinophilia or maybe parenchymal eosinophilia, right?
Okay,
so how often are you able to do that test in these patients? Or instead, would you consider doing something else, maybe a sputum eosinophil count, quantitative
Yes,
assay?
I was trying to tell you. Yeah, whether sputum eosinophil would be possible instead of bronchial lavage wash.
Okay, I do it very uncommonly, man. To be very frank, I do it very uncommonly. Perhaps the only real situation where I would say that bronchoalveolar lavage is mandatory will be a suspected acute eosinophilic pneumonia, for two reasons. Because it's one situation where you don't get peripheral blood eosinophilia, you just get ARDS like picture. So in that case, BAL becomes almost mandatory. And the second part, would sputum eosinophils suffice? My concern here is that, okay, you get a lot of eosinophils in sputum, probably you have a clinical impression that it may be a pulmonary eosinophilia, yes, go ahead. But then we don't have very well-defined cutoffs like what we have in peripheral blood or BAL. That's my concern. To the best of my knowledge, I don't think there are very good specific prospective cutoffs that have been worked out for sputum eosinophils for pulmonary eosinophilias. Maybe very good cutoffs for asthma and eosinophilic asthma and steroid responsiveness and all those things. So that's my take. That's my concern. But if not possible, probably a poor man's or less equipped man's BAL for eosinophilia may be translated to sputum eosinophils.
So
I think I would have opinions from other panelists also on that.
Yeah, I agree with Dr. Rajesh when you said that there is no definite cutoff. As in BAL, you have a cutoff of 25%. For sputum, you don't have a cutoff. That's the problem.
If somebody was to do the study, we'd find out, right?
Yeah, that's something we need. Yes.
Yeah.
Whether we can induce the sputum and sputum eosinophilia, I think Dr. Dasgupta will be able to highlight. It's not a very easy thing, and it needs a lot of expertise, isn't it?
Not really, because Indians are very
Right.
good spitters. So you have a lot of sputum available here and there. So keeping jokes apart, you could always induce sputum with normal saline or hypertonic saline. It's quite safe, given the fact that if the patient has a bad airways, then you could always pre-medicate with salbutamol first and then go ahead with your induction. And the test is not really that difficult if you have the hang of it and if you are really, really, really interested. So I don't think it's not feasible. It's very much feasible. You just need to have a very strong passion for that.
Irrespective
Yeah.
of the that cutoff value, I think these tests needs to be performed routinely because it will give you a lot of clues to the diagnosis in these kind of diseases, sputum eosinophilia, basically. Even
Agreed.
in COPD and asthma, to determine the phenotype, they recommend that sputum examination. So it is a good habit to start doing the sputum eosinophilia labels. And once adequate sampling has been done, we may define the labels as well,
Absolutely agreed.
cutoff values
We
as
need a
well.
cutoff. We need a cutoff to definite. Yes. Any other questions from the audience?
Yes, sir, we have a few more questions. Okay,
Okay, we can
what is
take
the
them.
duration of DEC treatment? This is asked from the audience.
So that
I think
that
Dr. Khan told that.
Mm-hmm.
Yes, Dr. Khan, you can again.
yeah, it is basically the duration of treatment is 3 weeks. Recommended is 3 weeks, and if the patient is symptomatic and there is a eosinophil levels remains elevated, then we need to prolong it maybe for 6 weeks or maybe longer. Maybe up to we can give up to 3 months.
So do we do the blood work in between to see if there is
Yes, we are doing the blood every 3 weekly, ma'am.
Okay.
After the 21 days, on 22nd days, 22nd day, we are doing the hemogram to find out the exact value of the absolute eosinophil count.
I've got a small question.
Yes, sir.
Yeah, diethyl carbamazepine citrate, is it discovered in India? Is it started from Kolkata? I heard that it has been discovered and practiced from India to start with.
No, I don't think so, because right now I will not say you confidently whether it has been discovered in India or not, but in filaria it has been used in Singapore by Dr. Dhanraj, basically. He was a man from the South India, I think, and he was practicing in Singapore, and majority of his patient was from the Indian and Pakistan and Bangladesh origin only. On the that 110 patient, what he's done the studies of the 6 milligram of per kg body weight of DEC has been given by Dr. Dhanraj himself from the he was practicing in Singapore. So I cannot say confidently whether it has been discovered. It was discovered in India
I
or not.
was just wondering, because tropical pulmonary eosinophilia has been described from India, whether the drug was also evolved in India in some part of the country, and we do not know about it. Perhaps could be possible.
Okay, maybe.
Anyway, thank you, sir.
Okay.
Thank you.
So I have a small announcement. Next week we fixed a session for what did I learn from COVID-19, perspective of insight analysis from different subspecialty experts. But we are not 100% sure whether we'll be able to hold that meeting, because 2 of our experts have expressed a bit difficulties. Maybe by tomorrow we'll be clear. We'll let you know by email. Next week, the next session is on pneumonia, where we are going to discuss the approach to pneumonia and a very critical question of differentiating viral and bacterial pneumonia in real world. Plus, there is also a question of preventing pneumonia. So, although we are not sure for the next week, next Sunday evening, we are very sure about the next Sunday evening. And if any of these episodes are dropped, it will be repeated surely in any of our future Sundays. So I welcome you all to join Pulmocon modules, which will continue till the NAPCon. And by chance, if any of the module is dropped, it will be performed after the NAPCon.
And I thank you very much, Dr. Parthuda, for it's a great effort on your part to continue this. And we are very happy and we are privileged to be a part
I
of it.
appreciate your contribution. I appreciate the contribution of our esteemed